that is hypothyroidism. Okay? Both of these topics are quite important from the exam point of view as well as from the clinical point of view. And trust me, if you pay attention to this discussion, you can easily diagnose a case of hypothyroidism. Let's move further. Now, hypothyroidism is exactly the opposite condition of hyperthyroidism. So here there is underactivity of the thyroid gland. There is underactivity of the thyroid gland. And most of the time it is again primary, means the disease is lying inside the thyroid gland. But it may be secondary because of hypothalamic pituitary disease. Hypothalamic pituitary disease as a result of decreased TSH secretion from there. And in that situation, we call it secondary hypothyroidism or central hypothyroidism. The primary hypothyroidism is one of the most common endocrine conditions all over the world. That's why we often see this in clinical practice. Just you need to have that open eye, you know. Sometimes what we say in clinical practice, if you have not studied this particular topic before, if you do not have head knowledge, even if the patient is right in front of you, you cannot diagnose it. You don't see those clinical signs at all. Okay, so that's why the head knowledge is very, very important in our career. We should know about the theoretical aspect first, and we must utilize this theoretical aspect in the practical sense. Now, let's move on. What are the causes of primary hypothyroidism? Primary means the disease lying in the thyroid gland. So what are the causes? So let's discuss one after other. The first has to be the congenital hypothyroidism. It may be there because of agenesis of thyroid gland or because of ectopic thyroid remnant. Now, what is agenesis of thyroid gland?
So there is
It is
absence
not
of
developed.
Absence of thyroid
not
gland.
Formed
developed.
proper.
Exactly. Exactly. Thyroid gland is not formed properly. There is absence of the thyroid gland, that is called agenesis. So naturally, it gives rise to hypothyroidism. Another one is ectopic thyroid remnant. Now remember the development of thyroid gland, which we talked before. There is a thyroglossal duct which starts from the foramen cecum of the tongue and it descends downward. Now, sometimes what happens, the thyroid gland is absent from its main site, but it is present in a smaller, size in that area where thyroglossal duct is present. So these are the ectopic thyroid remnant. Okay, and they are not enough for the source of thyroid hormone. Another cause is defect of hormone synthesis. Defect of hormone synthesis, like iodine deficiency. Iodine is the micronutrient which is absolutely necessary for the synthesis of thyroid hormone. Without iodine, thyroid hormone is not formed. So very easy reason, dishormonogenesis. Okay, the hormone is not synthesized properly, probably because of lack of certain enzyme. So what is the name of one important enzyme which is associated with thyroid hormone synthesis? Yes, what is that
Thyroid
enzyme?
peroxidase. Thyroid peroxidase.
Excellent. Thyroid peroxidase, TPO. Thyroid peroxidase or TPO. Never forget that name because we are going to talk about that, okay, later on. Antithyroid drug. Now see that. Just now we have talked about hyperthyroidism, propylthiouracil, methimazole, and carbimazole. These are the antithyroid drug. So how they act? They block the synthesis of thyroid hormone. So side effect has to be relative hypothyroidism. And other drugs like lithium, amiodarone, and interferon, they also can lead to hypothyroid condition, okay, by antagonizing the thyroid hormone or by inhibiting the thyroid hormone synthesis or by damaging the thyroid gland. Now, some other causes would be autoimmune, like atrophic thyroiditis, Hashimoto's thyroiditis, and postpartum thyroiditis. These three are example of autoimmune a damage of the thyroid gland, and once thyroid gland is damaged, definitely there will be hypothyroidism. Okay, among them we talk mainly about Hashimoto's thyroiditis and atrophic thyroiditis later on the slides. Another is post surgery. Now, if you remove the thyroid gland, then there is no source of thyroid hormone. Okay, if total thyroidectomy is done after malignancy, or even a big chunk of the thyroid is removed in subtotal thyroidectomy, then it may be one of the cause of hypothyroidism. Post irradiation, after 131 iodine treatment of the thyroid, hyperthyroid state, I already told you thyroid gland is permanently damaged. So this is one of the important cause, and tumors are definitely there, either primary tumor of the thyroid gland or secondary malignancy. Some other malignancy may metastasize to the thyroid gland and destroy it. So all of these are causes of hypothyroidism. Okay, very important question. Please repeat it until and unless you are quite certain about it. Now, what about the secondary? Secondary means there is something wrong in hypothalamic pituitary axis, like hypopituitarism, when overall pituitary gland is underworking, or there may be isolated TSH deficiency. Only TSH is decreased. Okay, both can cause hypothyroidism, but that is very rare in comparison to primary one. Another cause may be peripheral resistance to the thyroid hormone. Okay, that is not that common in clinical practice, but you can think about that as one of the cause. Now let's elaborate some of the important ones here. The first on our list is atrophic hypothyroidism, also known as autoimmune hypothyroidism. Now see there, this atrophic type of hypothyroidism. So this is the most common cause of hypothyroidism all over the world, and it is associated with anti-thyroid autoantibody leading to lymphoid infiltration of the gland and eventual atrophy and fibrosis. In other words, there is no goiter. Now, let me elaborate again. There is anti-thyroid autoantibody. Okay, they are mainly blocking and damaging type. So they cause inflammation there. There is a lot of lymphoid infiltration, and ultimately the thyroid gland will shrink in size. So as a result of that, there is no swelling or no goiter. It is much more common in females than in male because of autoimmune nature. This condition, just like any other autoimmune disease, is associated with other autoimmune phenomena or conditions like pernicious anemia, vitiligo, okay, Addison's disease, type 1 diabetes. So these are the other example. And here the antibodies which is present is blocking the TSH receptor. That's why it is causing all this problem. In comparison to this, Hashimoto's thyroiditis, okay, is associated with some other type of autoantibody, and in that goiter is present. Okay, please mute yourself and let's focus on the class. So we're talking about the causes of hypothyroidism. Another important cause is Hashimoto's thyroiditis. Now, what is this? This Hashimoto's thyroiditis is a type of autoimmune thyroid disorder, okay, where thyroid gland is destroyed. But it has one difference from the atrophic type of thyroiditis, that is, it leads to goiter formation. Now, what is the mechanism here? Yes, in the beginning, it also leads to some of the atrophic changes, but later on, that atrophic changes is, convert into regenerative phase. As a result of that, goiter is formed. So that is the difference between atrophic type of autoimmune thyroid disorder and Hashimoto's thyroiditis. Both are very common in female, and both are associated with thyroid autoantibody. During palpation, the gland is usually firm and rubbery. TPO antibodies are present. This is a very important feature of Hashimoto's thyroiditis. They are often present in very high titer, so they help us regarding the diagnosis. So what information you have learned here? If a patient, okay, has features of hypothyroidism, you first confirm it by doing thyroid function test. After that, you want to know what is the cause of that hypothyroidism. For that, these days, one routine test is done, that is anti-TPO antibody test. If that is present, probably it's a case of autoimmune thyroiditis like Hashimoto's. Patients may be hypothyroid or euthyroid, and they may go through an initial toxic phase that is known as hashitoxicity. Now, the mechanism of this hashitoxicity is, okay, because of initial inflammation, whatever hormones are stored in the gland, that may be released, outside. So for a transient period of time, there is hashitoxicity, which is followed by hypothyroid or euthyroid. Euthyroid means normal thyroid status. If the damage is not that severe, then of course euthyroid would be there. But if damage is done severely, then hypothyroid condition will develop. Levothyroxine therapy may shrink the goiter. Now, I like to ask the question here. Why levothyroxine therapy may shrink the goiter here? What is the reason?
The negative
Sir,
feedback to the pituitary, and there is less TPH, TSH, and
they will blocking the
no
TSH.
follicles.
Excellent. Okay, so see that? So you already got the concept. So this is the concept you have to take from this type of discussion. Very nice. Levothyroxine is the thyroid hormone T4. So when we give T4 from outside, it will give negative feedback to the pituitary gland. So there will be decreased TSH secretion. Whenever there is decreased TSH secretion, okay, the thyroid gland will shrink in size. So that's the perfect explanation. Very good. So let's move on. What are the clinical features of hypothyroidism? Please focus. This is an important part of today's lecture. The alternative term myxedema is very commonly used for hypothyroidism, myxedema, because of the deposition of mucopolysaccharide or connective tissue substances in the subcutaneous tissue. In this disorder, the term has been given. So myxedema is known as hypothyroidism in adult. The classical picture of slow, dry-haired, thick-skinned, deep-voiced patient with weight gain, cold intolerance, okay, bradycardia, and constipation makes the diagnosis quite easy. So these are the classical signs and symptoms which are written together. Slow patient is not active anymore. Okay, patient is very slow. Dry haired. Okay, there is hair fall also. The texture of the hair is not good. It feels very dry and they can break easily. And there is hair loss also. Alopecia, okay, can occur in hypothyroidism. And sometimes not only hair loss from the scalp, sometimes the eyebrow, okay, are also lost. Eyebrow can also be lost in hypothyroidism. Remember this. This is very significant problem, especially in female. The skin becomes very thick skin. That typical elasticity of the skin is lost, okay, and a texture of the skin is also very lost. Deep voice patient, because of hoarseness of the voice, the patient lose the normal quality of the voice because of that connective tissue substance which is deposited in the vocal cord. Okay, this problem happens. Weight gain is a very important feature of hypothyroidism. The person doesn't want to eat much, but there is constant weight gain, exactly opposite of hyperthyroidism. Cold intolerance is present here, just like heat intolerance is present in hyperthyroidism. Cold intolerance is present in hypothyroidism. Means they feel excessive cold because okay, because the metabolic rate inside the body is slow. That's why there is no regeneration, or I should say generation of the heat, or formation of heat inside the body, okay, is not much. So this patient cannot tolerate the cold. Bradycardia, very important feature, that means slow heart rate, less than 60 per minute, and constipation is a universal feature of hypothyroidism. So all of these we have to remember if you want to make the diagnosis. Let's move on. Milder symptoms are, however, more common and hard to distinguish from other causes of non-specific tiredness. Tiredness or lethargy is a very common feature of hypothyroidism, but tiredness or lethargy can also be seen in other disorders like anemia. Anemia is so common in general population. Okay, so this is the non-specific one, and many cases are detected on biochemical screening, that is thyroid function test. As a clinician, if you suspect hypothyroidism, okay, refer for thyroid function test. Now let's talk about what are the signs and symptoms of hypothyroidism, just like we talked about hyperthyroidism. See here, tiredness, okay, already talked about, or malaise. Weight gain, very important feature of hypothyroidism. Anorexia, they are anorexic but they still gain weight. Remember this. Cold intolerance, okay, they cannot withstand the cold temperature. They suffer from poor memory, especially if a child less than 2 years age develops hypothyroidism, then they suffer from mental retardation. But after that, the typical mental retardation is not there, but still a bit of poor memory is present. Poor memory is present. Change in appearance, this is called coarse appearance, because of the deposition of connective tissue substance on the face. The facial expression of the facial appearance is not normal. It looks like a puffy face, okay, puffy face, like a swollen face. But remember, this is not a fluid collection. This is mucopolysaccharide collection around the eye and on the other areas of the face. Depression is an important feature. Poor libido, okay, there is a decreased sexual desire. Goiter is a common feature of hypothyroidism. This is mainly because of iodine deficiency here, and also in Hashimoto's thyroiditis, there is swelling of the thyroid gland. Puffy eyes, just now talked about. Dry, brittle, and unmanageable hair, important feature. And they often complain of hair loss, okay, and even with extensive good caring of the hair, their hair doesn't look good. The skin is dry and coarse. There is arthralgia and myalgia, pain, full joint and the muscle pain, muscle weakness and stiffness. Constipation, very important feature. I always ask this in the history. Menorrhagia. What is menorrhagia? What is menorrhagia?
Excessive bleeding, sir.
Excessive bleeding in the menstrual cycle.
Exactly. Excessive bleeding in the menstrual cycle. There may be clots. The lady may pass clots during the period, or some of the lady may even have oligomenorrhea. Okay, so this is a bit of difficult to explain here, why both of these conditions may be present in some of the patient. Psychosis, coma, and deafness. Most of these features are because of collection or accumulation of connective tissue substances in different tissues or organs. And coma is present in Myxedema coma. At the end of this lecture, we'll talk about it. Now, let's talk about the signs. Mental slowness. The person doesn't have a proper memory. Okay, the person is not as brilliant or bright as the normal people. Psychosis or dementia. Ataxia, okay, unable to walk on a straight line is called ataxia. There is poverty of the movement. The person is not that mobile, and there is deafness. Okay, this deafness can be a sensory neural deafness or conductive deafness both. There may be peaches and cream type of complexion. This is a typical type of appearance in the patient, or you can call it coarse type of appearance. Okay, and sometimes there is hypercarotenemia in case of hypothyroidism. Hypercarotenemia. What is the meaning of that? Hypercarotenemia. Yes.
increase increase
Car-
beta carotene in the blood.
Keratin will increase.
Very good. Beta carotene or carotene is increased, and this carotene is the precursor substance of vitamin A. Okay, so as a result of this, the person looks slightly yellow, in appearance. This is known as hypercarotenemia. It can be a feature of hypothyroidism. So remember this as one of the extra features there. Probably because of this peaches and cream complexion may be seen. Dry, thin hair, okay, dry, thin hair, and very brittle type of hair. They may be lost easily. Loss of eyebrows, see there. And this is a very, uh, alarming feature in some of the girls or some of the female. And this they may go to the hospital purely because of this rather than other features sometimes. Hypertension is seen in both hypothyroidism and hyperthyroidism. Now, in thyrotoxicosis or hyperthyroidism, you know the reason, okay, because of overactivity of the heart, because cardiac stimulation is there, tachycardia is there, increased cardiac output is there, so there is systolic hypertension. But in myxedema or hypothyroidism, because of increased peripheral vascular resistance, okay, hypertension can also occur. Hypothermia, okay, hypothermia because of decreased production of the heat. Heart failure can also occur as a result of hypertension or because of some other mechanism. One of the important problem which occurs in this patient is pericardial effusion. Okay, bradycardia. See that pericardial effusion is written here. Cold peripheries, important feature. Carpal tunnel syndrome. You have studied that in orthopedics. One of the cause of carpal tunnel syndrome in hypothyroidism, again because of those connective tissue substance deposition there. They may compress the median nerve in flexor retinaculum area. Edema. This is non-pitting type of edema. We know there are two types of edema, pitting and non-pitting. This is non-pitting type of edema, which will cause swelling of different areas of the body. Periorbital edema on the face. Deep voice. Okay, this is again because of the infiltration of the substances in the vocal cord area. Goiter can also be there. Dry skin. Patient may be mildly obese. Okay, there may be myotonia or muscular hypertrophy, proximal myopathy, and one of the very important feature is slow relaxing reflexes. So what does that mean? When this type of patient comes to me, I will elicit the deep tendon jerk, especially the ankle jerk, and I will focus, all time on the contraction and relaxation of calf muscle, that is gastrocnemius and soleus muscle. So what will happen now when I hit the Achilles tendon with the knee hammer? Then there will be contraction of the calf muscle, but the relaxation takes a long time, and this is a very typical feature of hypothyroidism. And there may be anemia as well. And the type of anemia which is seen in hypothyroidism is a macrocytic type of anemia, usually macrocytic. Okay, so these are some of the very important features. You need to repeat this more than one time. Just focus on the highlighted one in the beginning and slowly try to learn other. Let's move on. Now let's see some of the picture here. Now, what can you see on this picture? Can you explain this? What can you see here?
Sir, there occur periorbital edema, sir.
Very good.
Puffiness of the face.
Puffiness of the face.
Very good. Very good. So you already picked the important finding. There is puffiness of the face. Look at the overall facial appearance. It looks like a swollen face. And look at this upper eyelid. There is definitely deposition of something there. The normal upper eyelid never look like this. Okay, this is called periorbital puffiness and overall facial puffiness. This is called coarse face, because the deposition of mucopolysaccharide substances, okay, the facial appearance is like this. And when we touch the facial skin, it feels very rough. The natural, texture of the skin is gone. Now, in male, similar type of features. Look at this facial puffiness here, periorbital puffiness as well as facial puffiness. Okay, the whole face looks like a coarse face, and the eyes are almost closed here because the deposition of the substances in the eyelid. Typical case of hypothyroidism. Now, this is macroglossia, okay, or big tongue. Macroglossia is one of the features of hypothyroidism, though it is not written there. Some of the features may be missed in that long list, but you have to remember this. Big tongue is a feature of hypothyroidism. Even in children, it may be present. Now, this is called xanthelasma. Every student know this. Xanthelasma is a feature of what?
Hyperlipidemia.
Hyperlipidemia.
Hyper.
Very good. This is a feature of hyperlipidemia. Hyperlipidemia. So you already know there is a connection between hyperlipidemia and hypothyroidism. Yes, in hypothyroidism, there is high chance of hyperlipidemia. Okay, because of those enzymes which are associated with fat metabolism, like lipoprotein lipase, hormone sensitive lipase. Okay, they are responsible for hyperlipidemia in this case. Now, one extra information I like to provide you here. Sometimes what happens, there may not be typical features of hypothyroidism. All those classical features we talked about, like constipation, cold intolerance, hair loss, okay, slow activity, lethargy, decreased memory, may not be present in every individual, but in the beginning, okay, they may be presenting with this type of feature like xanthelasma. And if we do lipid profile test, there is hypertriglyceridemia. So always think about thyroid function test, okay, as one of the important investigation if a patient presents with hyperlipidemia. Never forget this. And you can pick the diagnosis, and you don't need to treat for that hyperlipidemia. Just treat for hypothyroidism by giving thyroxine hormone. That lipid will automatically come back to the normal. See this, myxedema with carotenemia. Myxedema with carotenemia. Now, these are the, see this deposition, this such a thick skin, such a coarse skin on the dorsal aspect of the foot. And look at the slightly yellow appearance there. This yellow appearance is because of carotenemia. Now, there is one question, okay, which will be asked all the time. I'm sure you already know the answer though. It looks like jaundice. Sometimes jaundice is very easily confused with carotenemia. So how to differentiate between them?
Sir, in jaundice there occur yellow
Look
sclera,
for the
while in carotenemia the whole body is yellow.
conjunctiva and sclera.
Carotenemia.
Very
Yellow
good.
sclera in.
Very good. So I already got the answer. All the students are picking it correctly. In jaundice or hyperbilirubinemia, okay, that is a term for jaundice. Hyperbilirubinemia, there is deposition of bilirubin everywhere, all over the body. And the bulbar conjunctiva is the place where we never miss for the diagnosis of jaundice. That is usually yellow. Whereas in hypercarotenemia, that area is spared. Okay, it doesn't look yellow. That is one important point. And another one, we can always take the help of investigation. Just go for test. Go for liver function test. Okay, look for what is the total serum bilirubin level there. If it is elevated, definitely it's a case of hyperbilirubinemia. And to diagnose hypercarotenemia, you go for thyroid function test. Who knows, the patient may be having hypothyroidism. That's why carotenemia is there. Now, here is a picture which is showing us recovery after L-thyroxine. So before, treating the patient, she was like this. This is the face. before we started therapy, and after we treat with L-thyroxine, she became like this. Now see this, look at the facial puffiness. It almost disappeared. Okay, it almost disappeared. This rounded looking face is no more there. The eyes are very small here because of deposition of substances around the eye, but they're absent here. And where is the goiter? Look at the neck of this lady. There's a swelling I can clearly see. This is gone there. So these are the very pronounced change after we treat her with L-thyroxine. L means levothyroxine. Now we are towards the end of this topic. What are the investigation you like to do if a patient is suspected to have hypothyroidism? Just pay attention here. The first is thyroid function test. Thyroid function test. And in thyroid function test, I always like to start with T4 level. So T4 level will be low here. That's why it is known as hypothyroidism. After that, I go for serum TSH level. And this TSH level, okay, is very commonly, we always do this together actually, though it is written as the investigation of choice. Why it is written like that, I'll give you explanation. This TSH is very commonly done in the newborn period. For example, if a baby is born in the delivery room, and if we want to screen that baby for congenital hypothyroidism, we just go for TSH level, and TSH level will be very high there. Okay, that's why to accommodate all these different causes, they have written serum TSH is the investigation of choice. But before that, I need to confirm this is a hypothyroid state. So low free T4 level is the first test which I see. Then I'll go for serum TSH. Now, one small question here: if serum TSH is high, okay, which type of hypothyroidism is this? If serum TSH is very high, which type?
Primary.
Primary.
Exactly.
Primary.
Exactly. This is primary hypothyroidism. And if serum TSH level is low, this is secondary, isn't it? Or this is central. Thyroid and other organ specific antibodies may be present, like anti-TPO. Anti-TPO antibodies, if they are present, then this is clear-cut case of autoimmune thyroiditis. Now, other investigation apart from them include the following. See there? So what can we do and what are the reasons for that? CBC, complete blood count, is routinely done, and anemia is quite prominent or important feature of hypothyroidism, and this anemia is normochromic, normocytic, as well as macrocytic, or sometimes even microcytic. So there are different reasons for this anemia. Okay, but a very typical type of anemia which is present here is macrocytic. Now look at the different explanation for these different types of anemia. Normochromic, normocytic anemia is quite common. This is a chronic type of disorder. Okay, so anemia is quite common. But if macrocytic anemia is seen, then probably it is caused by pernicious anemia. What is the connection between pernicious anemia and hypothyroidism? Yes?
Autoimmune.
Autoimmune connection.
Connection.
Antibodies.
Autoimmune connection.
Excellent, excellent, very good. This is no clear-cut connection there actually. Okay, these two are very different situations, but one type of autoimmune disorder in the body may coexist with other autoimmune condition. Now see here, Hashimoto's thyroiditis is one of the autoimmune condition of thyroid gland. Pernicious anemia is of the stomach. So they may occur together, and pernicious anemia leads to megaloblastic or macrocytic anemia. Wonderful. Whereas if a lady develops microcytic anemia, this is because of iron deficiency, probably because of menorrhagia, which may be a feature of hypothyroidism. So that is how you give explanation there. Increased serum creatinine kinase level may occur with myopathy because of the muscle damage. Proximal myopathy is an important feature there. That's why this enzyme which is present inside the muscle is released. Hypercholesterolemia and hypertriglyceridemia. These are the features of hyperlipidemia. Hyponatremia may occur as a result of increase in ADH. Now, thyroid, hormone inactivity is one of the cause of ADH oversecretion, also known as SIADH, you can say. So in SIADH, hyponatremia is the finding. This is known as dilutional hyponatremia, and the treatment is very easy. Treatment is just restrict the fluid there. Give the fluid 2/3 of the maintenance and the patient will be all right. Another test we can go for is skull X-ray and chest X-ray. Now, why skull X-ray is done here? Any explanation? Why skull X-ray?
Sir, if there is the white Atrophic epithelial tumor in case.
Atrophy of pituitary glands.
Okay.
To identify secondary.
Very good. So the answer is quite correct. To find out the secondary type of hypothyroidism or central type of hypothyroidism, I want to do skull X-ray. Who knows? There may be a pituitary tumor there, and that pituitary tumor may be causing central hypothyroidism. If pituitary tumor is there for a longer time, then the sella turcica, which is the pituitary fossa, that may look quite wide, and I can pick that in normal skull X-ray. Okay, so that's the explanation. And chest X-ray, remember, pericardial effusion is a common feature of hypothyroidism, and in chest X-ray, pericardial effusion looks like a water bottle appearance. So we can find that type of appearance in chest X-ray in case of hypothyroidism if there is pericardial effusion. See here. Okay, look at this X-ray now. Here is the normal pituitary fossa. Let me highlight this. See here. This is the normal pituitary fossa. Okay, also known as sella turcica. Just compare this pituitary fossa with this one. See how wide is it? This is a very wide pituitary fossa, and this is because of the mass which has constantly given pressure, okay, on the boundary of this pituitary fossa, so it looks very wide. At the same time, this patient of course will have raised intracranial pressure symptom like headache, vomiting, blurring of the vision, okay, and some other neurological deficit. And never forget, it will also give compression to the optic chiasma. So there will be bitemporal hemianopia in this case as well. Along with them, other features of hypopituitarism may be seen because anterior pituitary is releasing so many other type of hormone. So all of those will help us regarding the diagnosis. Now see here, this is the chest X-ray. This chest X-ray is showing massive cardiomegaly, massive. This is a clear-cut case of pericardial effusion, and they have found out this pericardial effusion is caused by hypothyroidism. Okay, after we treat hypothyroidism with the L-thyroxine, this will disappear. Now see here, it has disappeared now. Where is a pericardial effusion there? The heart has come back to the normal shape. Now, lastly, what is the treatment of myxedema or hypothyroidism? We give replacement therapy with levothyroxine. The treatment is quite easy. So replace the thyroid hormone with L-thyroxine, and it is usually given for lifelong. The starting dose will depend upon the severity of the deficiency and on the age and fitness of the patient. Now see here, 100 microgram daily for the young and fit patient, 50 microgram, which we may increase to 100 microgram after 2 to 4 weeks for the small, old, or the patient who are having ischemic heart disease in the past. So this is a small guideline of how to use or what dose we should start in the patient. but you don't need to panic or worry. If the patient is producing the sign and symptoms of hyperthyroidism because of over treatment, you just decrease the dose. Just decrease the dose. And if you think the dose is not enough, just increase it. That's how we are going to do. Now, how to monitor the patient? How we know the patient is responding? The aim is to restore T4 and TSH to the normal range. Of course, it takes time though. Okay, so treatment is continued. And meanwhile, you ask the patient to come to your clinic or hospital time and again and examine the patient clinically. Take a good history. Go for the physical examination and do thyroid function test at least 6 weeks, okay, after you start the therapy, and judge whether your treatment is working or not. So this is known as monitoring. The usual maintenance dose is 100 to 150 microgram given as a single daily dose. And after that, every once a year, the thyroid function test is recommended. Okay, but remember what our patient think. They want the improvement very quickly. So the clinical improvement may not occur that quickly until and unless patient takes that medicine for a long time. At least 2 weeks time is taken for the improvement of the symptom, and full resolution of the symptom may take around 6-month duration. So we need to explain this, otherwise they will stop taking the medicine. They think, oh, this medicine is not working in me, so why to take it every day? So that is the mentality of our patients. So proper counseling has to be done, and in many patients we give lifelong therapy. Now, the last part of this lecture is a very important emergency situation that is called Myxedema coma. Okay, so let's discuss this and end today's topic. Now, Myxedema coma is a severe condition of hypothyroidism, and because of that the person develops unconscious state. That's why it is known as Myxedema coma. Some of the precipitating factors for Myxedema coma are infection, trauma, stroke, okay, hemorrhage anywhere in the body, or maybe intracerebral hemorrhage also, or use of diuretics. Okay, and regarding the signs and symptoms of Myxedema coma, the person may be mentally confused. This is a feature of hypothyroidism also. So in case of Myxedema coma, it is even more serious. Hypothermia and bradycardia. See that, nothing new. Apart from them, there is electrolyte imbalance. There is decreased sodium. This is again, we have explained, this is hyponatremia because of SIADH. There is hypoglycemia, hypercapnia or hypercarbia, decreased WBC count, decreased hematocrit or hemoglobin, and increased CPK. Okay, these are also quite easy to understand. This hypercapnia is because of a labored type of breathing. Labored breathing, we say. If you do ECG, there is decreased ECG voltage. This is because of pericardial effusion. Okay, there is features of myxedema, and there is beta carotenemia as well. So these are signs and symptoms. So not much different from the typical case of myxedema. Regarding the treatment, this is an emergency situation already talked about. So patient is transferred in the intensive care unit. We treat the patient with T3. Now T3 is the active component of the hormone. So this T3 is given intravenously every 6 hours here. Okay. Patient is kept under mechanical ventilation, especially in case of increased carbon dioxide and if the patient is in coma. Mechanical ventilation therapy is very essential. We can give hydrocortisone IV. Passive warming of the patient is necessary because of decreased temperature, and careful volume management should be done. Now, why careful? Because heart is already affected. So if you give too much volume, probably you will precipitate a heart failure again. So these are very important points in the treatment of Myxedema coma. So remember, this is one of the emergency situation of hypothyroidism. Okay. At the end, I just like to say one sentence here. When a newborn baby is born in the delivery room, we are not sure whether that baby is born with hypothyroidism or not. That is called congenital hypothyroidism. One screening test we can do, and that is, okay, screening of high TSH level, and that can be done with a blood spot, and that is really help us to find out congenital hypothyroidism in time and go for the treatment quite early. If we miss, the baby will suffer from cretinism